Good afternoon, everyone, and thank you for joining me for today's live discussion on mental health during the pandemic. I'm Orizo Hajigurban, the engagement reporter for the Sacramento Bee's Equity Lab. Today, we're going to be revisiting a conversation we had almost a year ago exploring California's approach to mental health during the pandemic. For this discussion, we asked the readers to submit questions. If you were not able to submit your questions beforehand, not to worry. We'll be taking questions during this live event in Facebook or YouTube comments, and we will do our best to cover as many of your questions as possible toward the end of today's discussion. To learn more about the Equity Lab, follow us at EquityLab_SAC on Instagram and Twitter, and at Equity Lab SAC on Facebook. We'll pin a comment on Facebook and YouTube so you can easily find us via those links. If you are joining us on sacb.com, thank you, and you'll find links on the story page. We're almost 2 years into the pandemic. Symptoms of anxiety disorder and depressive disorder increased considerably in the United States from April to June of 2020, compared with the same period in 2019, according to a study done on mental health, substance use, and suicidal ideation during the COVID-19 pandemic by the CDC. I'm joined here today by Karen Savage Sangwan, the Executive Director of the California Pan-Ethnic Health Network, Sandra R. Hernandez, the President and CEO of the California Healthcare Foundation, and Vinder Lalian, the Counseling Director at My Sister's House, the Central Valley's only shelter for abused Asian and Pacific Islander women. Before we dive into our discussion, I wanted to let you know that support is available. If you or someone you know needs help, please call California Peer Run Form Line at 1-855-845-7415. You can also text Talk With Us to 66746. So to start, I wanted to ask you, Vinder, as the counseling director at My Sister's House, how have you seen a shift in how people are reacting now versus earlier on to the pandemic from a mental health standpoint?
Thank you. Thank you for having me here today. We have seen a shift, but we've also seen a lot of the same struggles. I think women who are experiencing domestic violence, sexual assault, and human trafficking are experiencing a lot of, in addition to that, experiencing a lot of anxiety. I think they're having, continued challenges with resources, accessing resources. And I think as staff, just being able to balance safety. I think COVID has added another layer, a barrier, really, essentially, to having clients come in and get that sort of face-to-face. Although we're open, we have definitely had to implement, protocols and things like that have made it a little bit more challenging, but we're still able to provide services. But I think COVID in general and going through the pandemic, it's just important to realize that it has been very traumatic. I think we're all very traumatized, just by hearing and seeing, even if we ourselves have been healthy and lucky to be healthy, but that's just another layer that we're seeing that's just making it that much more challenging for clients to get out, for victims and survivors to get out and get help. So we've just been trying to be mindful of that and do what we can do to meet them where they are.
So since you work with the Central Valley's only shelter for abused Asian and Pacific Islander women, My Sister's House, how have you seen the trend in domestic violence and the correlation between that and mental health since the pandemic started? Were there any specific things you noticed in certain communities compared to others?
Yeah, that's a really good question. I think what we have really seen specifically, in addition to our clients seeking services for domestic violence, it's also the anti-Asian hate. That has been a huge addition. Lots of our clients in our shelters, those who come through for other services, share stories about what they have experienced. We hear it in our groups. And so, that has definitely, I think, added sort of what's been happening in our community, at the sort of political level and at the social justice level. And I think because we do focus on Asian Pacific Islanders at our agency, we definitely see that sprinkled. And it does add another layer to why it's been really, really difficult for some of these women and survivors to get out and get help. So not only is there the fear of leaving the domestic violence, but in addition, there's the fear of what's happening out there in the community simply because you're Asian.
Mm-hmm. Thank you so much. Karen, I know you spoke a little bit on this about a year ago, but since then, as you take a look at what's happening across the state, do you have any specific examples of a community-focused solution that was put into place to help support those communities that were affected more than others? How do those approaches in the beginning of the pandemic differ from what's going on now?
Yeah, and thanks for the invitation to be here. And I appreciated the comments that were just made. I think it's really important for us to be thinking about, we have a COVID-19 pandemic, but for communities of color, we're also living with generations of structural racism and the impacts, the stress and the trauma on communities. Because of that, it's really important for us to consider this. It's not sort of a single issue crisis, right, for communities of color. And I think when we look at the pandemic itself and a lot of what it did, particularly in the beginning, was force us all to sort of live in a way that frankly is the opposite of what we generally advise people, right, for maintaining mental health and well-being. We told people to stay home. We told people to isolate, and all of those things were necessary, right, to control a virus, respiratory virus. But really, I think communities had to adapt to figure out how are we going to meet the needs, meet the sort of the mental health needs, and really what we think of as like build the protective factors. Because when we have communities that are sort of facing all of these harmful issues, what we have to do is build protective factors, right, to be able to maintain a level of mental health and well-being that enables people to continue their lives. And so I think communities and community-based organizations really stepped up with their knowledge of communities across the state in different populations, really small ethnic populations that we have here in California, and a major statewide campaign. And so I think, communities really showed like their ability to develop innovative solutions to pivot and to meet those needs, and were critical. And so, some of the things that we saw, people being really intentional in their communities about developing culturally specific ways to reach out to our older adult population who are among some of the most isolated, right? Developing sort of mutual aid systems of reaching out, making sure that people stayed connected, and making sure that people were able to stay connected with people in their community who had a better understanding of what they were dealing with. Again, not just the pandemic, but anti-Asian sentiment was mentioned. We're living through a number of crises that really deeply impact communities of color. So some of those programs were essential. We saw some community-based organizations that were able to adapt some of the programming that they generally do in person and think about, for example, how does a virtual support group look different, and how might it be effective in different ways, right? You certainly lose some of the in-person connection that makes for that valuable service, but you can do other things like make it easier for people to participate, right? So I think communities and community-based organizations were really able to adapt in some of those ways to meet some of the needs, although I don't want to underscore or underestimate the amount of unmet need that there does continue to be in communities.
Thank you, Karen. So talking about, losing that personal connection, Dr. Hernandez, I wanted to ask you about telehealth. In your conversation almost a year ago on the same topic, you spoke a little about telehealth and how it was used earlier on in the pandemic. Can you talk to me a little about how it's being used now compared to the beginning of the pandemic, and how you see it being used in our favor in the foreseeable future?
Yeah, sure. Thank you. It's nice to be with you this afternoon and be part of this panel. Yes, I mean, telehealth was sort of lurking in the background as a potential tool to be able to perhaps reach people in rural areas, in some cases to help get access to subspecialty care. But really the pandemic really flipped a switch in terms of the utilization of telehealth and technology in general. To be able to provide a lot of services, including in the areas of mental health and behavioral health during the course of the pandemic. And what you've seen over the last year are a lot of our safety net providers, our community health centers, our clinics, some of the big hospital systems. Really, there is a big infrastructure now that is being developed, including a lot of startup companies who have a very specific focus in trying to expand access to behavioral health and mental health services in particular, working with schools and providing telehealth capability in schools, providing online platforms. The state of California developed one that has a lot of tools that young people can go on that are interactive, that are peer-driven and the like. So what we're seeing is really a proliferation both in companies that are trying to address this need. And keep in mind, all the comments that were made earlier are certainly true. And it's really important to realize we have, before the pandemic, a significant crisis in just the workforce that provides mental health services. It's true for children, it's true for LGBT communities, it's true in terms of culturally communities that have particular cultural needs or language needs. It's true in the elderly community. And so how do you leverage a limited workforce? Well, telehealth ended up being a significant solution for that. So over the last year, you've seen these clinics and hospitals and providers really begin to figure out how to use those tools at scale, how to leverage a very limited workforce, how to do team-based care, both integrating kind of the community-based services that Karen was talking about, but also importantly, being able to take primary care in places where people go for primary care and for prevention services, and be able to link behavioral health into primary care using technology and telehealth tools. So really, I would say, telehealth was in a nascent form pre-pandemic, and really is now being explored, expanded, and scaled statewide to try to address this very significant mental health crisis that is built on top of a public health crisis, which of course is built on a racist health system that Karen already discussed. So I think that what we're going to see in technology is a continued expansion of those kinds of services. And I think the next part of this will be to figure out which of those work and how well do they work and how much engagement do we get from folks who use telehealth. If you ask low-income folks, which the California Healthcare Foundation has done, and you ask them, sort of what is the biggest health issue you're facing? Before the pandemic, it was mental health. And here, coming off of a pandemic where everybody has been impacted to some degree or another from a mental health point of view, it's a moment in time where I think we have the potential to destigmatize mental health and to have it be seen as something that everybody needs at some form and in some way. And what you see in California now from a policy point of view is not only are we paying for, importantly, telehealth services on par with physical health services, but we're also going to need to evaluate those services and make sure that they work effectively, even while we continue to significantly invest in the healthcare workforce that has expertise in mental health and in substance use disorder.
Thank you, Dr. Hernandez. Karen, I'm going to throw it back to you. Is telehealth being used as much now at your organization as earlier on in the pandemic? How have you seen it be successful with patients, and how has your organization faced the challenges with using telehealth?
Yeah, so we don't provide direct service, so we don't ourselves provide telehealth services, but what we have done is we have looked at how telehealth is working specifically for communities of color and people with limited English proficiency or people who have a primary language other than English. And we've looked at, is it working as well in those communities as broadly? Because, we have concerns, right, about access, about broadband, all of those things. And I think we were pleasant. We did some surveying, polling in communities sort of, end of last year, almost a year ago, when we were still sort of building our telehealth capacity. And what we found was sort of overwhelming satisfaction with telehealth in communities of color broadly. People who really felt like they were able to access healthcare more easily, more frequently, have that connection with their provider, a real appreciation of it. But we, I think, interestingly, did find somewhat lower satisfaction for behavioral health and for using telehealth for behavioral health treatment. And I think part of that from the responses we received is, it can be difficult, right, to have the same connection when you're talking about mental health and wellness over a video or phone platform, or even a texting platform, which we're thinking about. So I think there's a lot. I think Sandra's point about evaluation is really important, is something the state needs to think about as we continue to expand the use of telehealth. And then there's the things that we know we need to fix about it in order for it to work as well as it can work. And one of those things I would point to is language access. So interpreter services, which sort of surprised me, because I thought, if we're doing care virtually and we were already doing a lot of interpreter services virtually, it would be easier to put it all together. And in many respects, it's actually been harder. And we've heard more from people who don't get an interpreter when they're using telehealth than, for the in-person services. So there are some of those things that we really need to focus on overcoming. But I think in general, it's a very welcome development in communities of color.
Thank you, Karen. Vinder, what about you? How has telehealth worked for your organization?
Yeah, thank you. We had to pivot to telehealth immediately, right when COVID hit, because so many of our clients absolutely have to be in therapy. Some of them are meeting requirements for CPS. They're trying to, work towards getting their children back. So we had to sort of figure it out very quickly. And a lot of our clients, as Karen was saying, do require an interpreter. And so we've been, in my opinion, very effective in using telehealth, but also offering that interpreter service that joins us, for our sessions. So I think it's been surprisingly a really good experience. I was sort of a little, I guess, kind of sort of afraid of, oh my gosh, like, what is this going to be like? I'm a very sort of in-person person, but surprisingly, telehealth has been very effective. I think in a lot of cases for our clientele, because they have so many barriers often to getting into the office, like transportation and children, some of them are single moms or they don't drive, that telehealth has really offered them an opportunity to get on therapy, get some therapy. And also, as Dr. Rodriguez had shared, sharing just having access. We do still have concerns, though, about how to access sometimes services or give access to those who are still in their domestic violence. Telehealth can be very challenging, and it really may not be an option, a safe option. So we're still trying to navigate that. But we have had actually sometimes a greater turnout with telehealth, just because some of those barriers have been removed. But in a group setting, the interpretation is still a challenge. And so we still have to figure out how to continue to work on that. But otherwise, we've pivoted, and it's been, surprisingly a really good, I think, opportunity for us and for our clients to get those services.
That's great. I'm really glad to hear that. Thank you. So in the discussion about mental health during the pandemic last year, Karen and Dr. Hernandez, you explained what was on your radar for the future of the pandemic. I'm interested in hearing how that answer may have changed. And now that we're this far into the pandemic, what exactly is on your radar for the future of mental health? And I'm interested in hearing all of your answers for this. Karen, I'll start with you.
Sure, it's a great question. And I will say, I think there's been a number of improvements on the state level in terms of investments in our state budget, in terms of policy changes that are really important, were things we were looking at and hoping for last year, and were able to happen. So I think there's been a lot of progress. But I do think there's some sort of major policy issues that remain and things that we need to be looking to moving forward. So the first one is I do agree with the comments that were made, that I think there's an increased recognition that everybody has mental health, and sometimes many of us need help with our mental health, right? And it's not uncommon, and it should be far less stigmatized than it is. And so one thing that we're thinking about is, how do we have a system where people have more regular connection to behavioral health care, in the same way that we strive to make sure that everybody has a primary care provider? How do we make sure that everybody has sort of a a behavioral health home is how we think of it, or a place where you can go that's a part of your healthcare, that's regularly available to you, whether you need sort of a one-time assistance, maybe therapy, something like that, or whether you need more intensive, but making sure that part of our system of care as we continue to transform it is that everybody does have that connection to behavioral health, again, in the same way that we strive to make sure that everybody has that connection to primary care. In order to make that happen, we need really significant investments and changes in our workforce, because we don't have the workforce to make that possible right now. And so what we look at when we think about behavioral health workforce is how do we better engage providers who are sort of our non-traditional providers, right? So thinking beyond your psychiatrist and your psychologist, and thinking about peers, so people who have their own lived experience with mental health challenges, who are incredibly effective at assisting others with their recovery. Thinking about community health workers, who are people from communities who speak the same language, who understand the culture, who can, again, be really effective mental health ambassadors. Really leveraging those folks as part of a team, embracing and respecting their roles, I think is going to be critical. And just one or two more things that I'll add, I think we're increasingly understanding that we need to think about mental health care across the lifespan. So there's been a very significant investment now this year in children and youth and their behavioral health, and tying it to schools, something that we think is really important. We also need to be thinking about our older adults, right? And what are their specific needs when it comes to mental health and wellness, and how can we design the right services in the right place for our older adult communities. And then finally, I'll say we continue to really, I think, work towards how do we sort of decriminalize mental health and also substance use, right? Because, we traditionally have responses, particularly in communities of color, that really can send people to the wrong place, right? Whether it's people getting arrested because of things that are really a mental health or substance use concern, or people ending up in hospitalization that's not the right place for them. So really moving towards a system where we truly understand that mental health and substance use are part of our health, and that our responses need to be healthcare responses.
Thank you, Karen. Dr. Hernandez?
Yeah, thank you, and completely agree with Karen on this question of really how do we think about a community supporting a community as we try to address mental health issues that are acute, associated with the pandemic, that were chronic associated with the pandemic, and or that we might actually see as we come out of the pandemic. I want to sort of name 3 areas that, a year ago we probably didn't touch on, and that I think really do call out our attention. Seniors were already mentioned, but we also have an enormous mental health issue in our healthcare workforce. So there was burnout that was being discussed in healthcare well before the pandemic. Here we are 2 years into a pandemic with people struggling with COVID, with mandates, with emerging information, with all kinds of social unrest associated with how to best control a public health disaster like COVID-19. And so our healthcare workforce itself is facing an enormous mental health challenge that is manifesting itself as burnout and in early retirement and the like. And that industry itself is beginning to ask itself, how do we support our workforce so that a mental health issue that happens with a nurse or a social worker or a surgeon or an emergency room physician also has a peer response and a workforce response and an employer response that really makes it easy for people to say, hey, I'm having a problem, and B, here's what I need to be able to do to reach out and get help. And so the workforce of public health and in primary care and across our whole healthcare delivery system in itself is in the middle of a mental health crisis, and one that I didn't want to go unnamed in this program. And the other, Karen mentioned that the state does have a bold plan for children and youth behavioral health and a really comprehensive look at redesigning the system. Important to note that there are 140,000 young people who who lost a parent or a caregiver during the course of this pandemic. And those are just young people under the age of 18 who've lost somebody in their life who loved them, cared for them, fed them, took care of them. But there are also all kinds of people who know people who died of COVID, particularly in low-income communities and particularly in communities of color. And so that loss and grief associated with COVID is one that we're going to need to think about how we come together as communities at a very local level to give support for that legitimate grieving. Keep in mind that the pandemic also suspended a lot of the cultural norms and rituals that people use to deal with grief. And most of those were suspended during the course of the pandemic. And so grief has sort of been put on hold and is such an important stressor that we need to pay particular attention to that. I'll note, by the way, that just yesterday, the CDC officially announced that people who have schizophrenia, for example, previously diagnosed, are the second most likely to succumb of COVID-19 after elderly people. That's another really important point for us to pay attention to. People who had pre-existing serious mental illness continue to be at risk for COVID-19 and for the sequelae that are more serious associated with that kind of infection. So we are not yet over the focus on mental health and mental health screening and testing that allows us to prioritize resources so that we can prevent the untoward effects of having a COVID-19 infection itself. So I think those are populations we absolutely should not lose sight of. I just wanted to build on something Karen said as it relates to building a system of care that relies on health workers and promotores. That's a super important asset that we have in our community that allow people to have conversations about grief, about stress, about loss, about fear, about uncertainty. And those are conversations that are going to need to be normalized in communities where there is trust. And what's interesting about this pandemic as it relates to mental health is that everybody is experiencing some degree of it. And thus it is in our more daily conversations, much more so than it has ever been, in workplaces of all shapes and sizes. And that gives us an opportunity to really destigmatize the need for mental health and for the kinds of services that help prevent the chronic diseases that come from chronic stress and that mental health is part of. So I think those are things that are newly emerging as we are coming, what we hope is out of the most acute part of the pandemic and moving into much more of an endemic phase. The opportunity to really have mental health be an integrated part of healthcare maintenance and wellness and resiliency, because everybody has suffered some degree of mental health stress during the pandemic. That's a very unique opportunity that I think we have and that we should embrace, both from a services point of view, from a community point of view, from a prevention point of view, and from a systems point of view.
Thank you so much, Dr. Hernandez. Vinder?
Well, that was all very well said. I'll try to sprinkle in a little something. You know, as they were sharing, I was thinking about vicarious trauma, exactly sort of what was just talked about, that, you know, as providers, whether you're a therapist, a social worker, a nurse, a doctor, you know, a firefighter, you're a teacher, we are very much being affected by what's going on in the community. So not only are we affected because we're human beings first, with what's going on in our personal lives and what's happening sort of in the world, but then we have another layer of being impacted directly by the work that we do. And so we are experiencing our own sort of vicarious trauma. And, you know, exactly, you know, as, you know, what was shared previously, we are sort of the face of hope. You know, when we work with clients, when we work with children and teens and survivors and all the work that we do, we have to be the face of hope. And so we have to be able to also take care of ourselves. And I know there's this notion of self-care and self-care. But yeah, we are short-staffed, and, people are getting burnt out. And so absolutely mental health needs to be part of, the services and resources that are provided to staff, whether it's a community-based organization, whatever it might be, that it's part of your sort of coverage, so that everyone should be doing that. And honestly, there are so many symptoms related to mental health, that because people are not getting that support, they're going to the hospital. And so we really have to think about, putting sort of that time, money, and effort and energy into providing mental health services, because if we can do that, we can really take some of the pressure off of, the hospitals and sort of the medical side of it. When we work with, our ladies, often their first point of contact for any type of help is the hospital. That's where they go, especially with populations such as, the Asian Pacific Islander communities, where, it's not popular, it's not part of your culture, it's not the norm to talk and share. And so you internalize, and those symptoms come out, physically, and that first place you go is you go to the doctor. But then getting access to mental health is just, it's practically impossible at times. So I think we definitely have to do better at adding mental health into, just all of the wellness, and really it is so important. And if we can do that, we can really help take the pressure off of, some of those other places where we go. And then I think just cultural barriers, right? As shared before too, with COVID, we have been isolated, right? So our prayer, our rituals, those things that are really important to us, our coping mechanisms have been taken away. And so we have to do better. And one of the things we try to do is go into those communities, right? Meet with a pastor at the church, or, provide a presentation at the local mosque, or we try to do some of those things to find a sort of a safe way to provide education and support to community members who may not otherwise have access to those resources or even know about those resources. So I think in general, we just have to continue to keep doing those things to really get that word out and education. Because as much as we're doing that, often in specific communities, they don't know that there are services available. So we just have to keep pushing that forward.
Or so could I just follow on that? Something that she just said that I thought was worth building on. It's certainly true that we want to build a lot more prevention and early intervention into our mental health system. California Healthcare Foundation really does look at the whole continuum of care. And one of the things we've seen in the pandemic, which I think we didn't mention last time because we really didn't have as much data, is the fact that during the pandemic, if you looked at ER uses for people under the age of 18, the vast majority of those were for a mental health crisis. And it is important to know that mental health crises, we have seen an enormous amount during the pandemic, and we don't expect to see those necessarily decline as the pandemic wanes. And yet, we have very few acute care beds across the state of California that are dedicated to pediatric psychiatry, or really any psychiatry. And so while we certainly want to do as much early screening as possible and community-based interventions and peer-based interventions, it is still true that acute mental health issues need acute resources, for which we are vastly under-resourced in the state. It is a workforce issue, it's a licensing issue, it's a reimbursement issue, and it's one that is quite tragic, because when parents have young people that are in crisis, you take them to an emergency room and there isn't a bed for them, they wait hours and hours and hours and hours for a bed when they're in a very unstable mental health situation. So I think it's important to look at the full continuum, and we've been talking about how important the community-based continuum is, but I wanted to also name the fact that we don't have good acute care capability, and we don't have a good aftercare capability as well. And then the last thing that we haven't mentioned that I think is important to name is that we've also seen an enormous amount of opiate-related deaths during this pandemic, which we'd spent a lot of time focusing on substance use disorder and trying to develop a delivery system to adequately address that. And then the pandemic hit, and of course, rightly so in some way, we shifted our attention to a significant public health crisis. Meanwhile, we really had a significant amount of opiates that are continuing to make their way through communities all across the state, and associated with that have been a large number of opiate deaths. And so this is one of these things where it's easy for us to get distracted. During the HIV epidemic, we kind of took our eye off tuberculosis to manage HIV. Here we are with COVID-19 pandemic and take our eye off opiates. And I think it's really important for us to recognize that if you don't have in your mental health system access to a full continuum of services, people will self-medicate. They will self-medicate with alcohol, with drugs, with opiates, and the like. And that is as much a reason for us to focus on building out this continuum as is COVID-19 and the manifestations directly of surviving through a pandemic.
Thank you so much, Dr. Hernandez, for bringing up those very important points. Something else that was discussed in the previous discussion that I think is an important point, and I would like to hear all of your thoughts on this as well, is the effect of racial inequities on mental health. What are you looking at with respect to racial equity in 2021 going into 2022, and how can we be better? Oh, Dr. Hernandez, I'll start with you this time.
I'm happy to start. I mean, this is, I think that what we've seen from COVID-19 has just been what we know is true, which is that all of the social contributors to ill health that exist in society, poor air quality, lack of good food systems, lack of economic opportunities, lack of affordable housing, all of those systems contribute to the kind of racial inequities that saw COVID disproportionately impact our African American community, our Latino community, our Latinx community, Black community, et cetera. And so, and at the same time, I think all of our healthcare systems look at the data and say, we're spending 18% of our national GDP on healthcare. How can it be that we have such poor outcomes, whether you're looking at COVID-19 or whether you're looking at hypertension or the like? And so we're at a moment in time where all of the health systems are having to take a look and ask itself, what are we doing to actually promote health and reduce these systems of racial inequity that are embedded really in all of the systems that contribute to today to poor outcomes. And those conversations are quite rich. You're talking about overturning 300 years of racism. That's not something you do overnight. And yet, if you look at what we did in California as it related to COVID-19, looking at these indicators on a county level, looking at 21 indicators, transportation, food programs, transportation programs, food stamp programs, et cetera, it is a way to be able to target resources effectively by saying, if in a particular census tract you have this kind of outcome, and in the neighboring census tract you have that kind of outcome, we should target resources to address those inequities. And hospitals and clinics and provider groups all across the state, and in many cases across the country, have really very much leaned into doing that. A lot of that does require good data and good data collection, and data that actually gives you the kind of nuance with regard to ethnicity and cultural background and language capabilities and the like. And it also taught us that you cannot have an effective public health system that is disconnected in infrastructure and data from your healthcare delivery system. That fragmentation bodes very poorly for populations overall. And I think there will be many lessons we will learn from the pandemic, and where we put emphasis coming out of the pandemic to address the things that handicapped us so much in both mounting an effective response to COVID-19, but also importantly to protect communities that disproportionately are at risk for cancer, chronic diseases, malignancies, et cetera. And so I think we're at a moment in time where this disruption that the pandemic created, compounded by a real reckoning about racism and how it manifests itself in our health systems, in our educational systems, in our housing programs. All of those systems are trying to address today these racial inequities. And one of the things we have to recognize is you can't have good health outcomes simply by having a good hospital. You have to be able to have these systems interlink, because in fact, that's how families and communities use programs and use services. So I think we're going to see more integration, better data collection, better targeting of resources, and a recognition that our cultural diversity has inherent in it a lot of assets. We tend to think about communities from the deficits of economic power, political power, all of which are true. But communities also come with rich, diverse assets for resiliency. And we need to figure out how our systems and policies tap into those in order to make much more effective policies from the point of view of racial equity and ultimately better health outcomes for communities and populations at large.
Thank you so much, Dr. Hernandez. Vinder?
Yeah, I was, as I think about this question, I really, sort of think about our agency. And one of the things that comes up for me is just, looking into the future, we really just need people who are passionate and people who are willing to help. At our agency, we have so many volunteers who go through our trainings, and they are moved, to do this work. And they bring so much, whether it's their own life experience, whether it's, their culture, whether it's their religion, whether it's their ability to speak another language, whether it's because they've, spent 5 years in Japan and they have a passion for Japanese culture, whatever it might be. It is so, so important, that if you're home and you have that passion, share it. There are so many opportunities for you in the community, not just at our agency, but all around. And I think, what people need is when you finally take that step and you're vulnerable and you go somewhere, or you pick up that phone to make a call, or you go into an agency, or you go to that group, even if it's virtual, you want to feel like you fit in, that people understand you, they get you, you feel comfortable. And so we need people who are representative of our community. And so, just here in Sacramento, there's so much diversity. And, that's one of the most, I think, powerful experiences we have is that's sort of what clients remember. That's what they come back for. That's why they attend groups. That's why they log into the Zoom, is because they get it. Whether it's talking about, what you made for dinner and everyone can relate, or sharing a story about, a cultural experience and others can relate. I think really, really important that if you have that passion and if you have that inside of you to go forward, find a local agency, find something in the community where you can share that. Because as some of us staff sometimes do have those moments where we need our own self-care, we need a break. It's so, so nice to know that there's others, our amazing volunteers and other people in the community who can bring that. That's, I think, something that's really, really important. And I hope to continue to incorporate that into, the future years, especially with, all of those inequities that we're experiencing. So thank you.
Thank you so much, Vinder. Karen?
Yeah, so I think your question about where do we go from here on racial equity is a critical one. And I think it's important for folks to know, we have documented through medical research that exposure to racism is a significant risk factor, both for mental health challenges, but also for physical symptoms and challenges, right? That it's something that impacts people, impacts their mind, it impacts their body. And so as long as we continue to have a society that's very much built on this foundation of structural racism, it's something we have to grapple with. And so I think the point about the resiliency and the assets of our communities is so important because, again, that's the protective factor that we have that really enables us to support communities, to support ourselves and our own mental health. And I think, it's really incredible to listen to Vinder describe their agency and the work that they do and why people keep coming back, because I think what you described, Vinder, as the role of your agency and the way that women in the community feel about your agency is exactly what we want to see sort of all of our healthcare systems look like for communities, right? And feel like for communities. And so for us, that's about how do we shift sort of who's at the table and who's in the room to design our systems of care, right? To design our mental health care system, to design our healthcare system, so that really is reflective of our communities. And again, so that all of our systems can be more like places like my sister's house.
Thank you so much, Karen. So this is an audience question from Felicia Vasquez in Sacramento. The pandemic has caused severe levels of burnout for professionals within the mental health field. Given that burnout was already a very concerning issue before the pandemic, how will mental health service programs address this crisis? I know some of you already touched on this earlier in our conversation, but Dr. Hernandez, can you start by telling me your thoughts on this?
Yeah, I mean, this is a very, it's true in the mental health space, but it's really true in all of our healthcare professions, our nurses, et cetera. I think it's really, I think Vinder said this earlier, it starts with a recognition that we're all human first, and we're all members of our family first. And that is the notion that you just sort of show up and go on and move on because you're a healthcare provider or mental health provider really does not serve us well. I think what we need to be able to do is acknowledge when you're exhausted, acknowledge when you need a break, acknowledge when you need a timeout, acknowledge when you actually need more formal help. And I think really here, much as we've talked about peers in other spaces, a mental health professional talking to another mental health professional about how they're personally feeling can be very, very challenging. And yet that is an important form of support. We're in a post-traumatic stress disorder type of environment. And we have a lot of evidence about how to address that kind of stress. And the first is to acknowledge that you are burnt out, and there's many tools and assessments that you can look at to do that. And then really to do what it takes to step back and care for yourself, including if that means stepping out for a period of time and rejuvenating. There's all kinds of programs about self-care, walking, exercise, yoga, hydration. There's this enormous need for fun. One of the things that we spend a lot of time thinking about is how can we put joy and fun back in our life in virtual parties and virtual celebrations and virtual potlucks. So I think there's an element of acknowledging how you feel. There's utilizing and tapping into the resources that exist, and most of the professional associations have tools and resources available for this. But it first and foremost, just like with anybody else, is recognizing how you're feeling and being willing to do something about it. This is something that is true for mental health workforce, for really our entire workforce across the board. It's been an exhausting period of time to see so much suffering, so much, the way people succumb to COVID is just really incredibly traumatic in and of itself. So whether it's, somebody else mentioned, whatever spiritual inclinations one might have, I think there isn't a one size fits all, but it does come first and foremost with recognizing that you really can't be there for somebody else if you aren't first taking care of your own mental health and your own well-being. And we should just acknowledge, anytime I interface in any way, shape, or form, whether it's at Walgreens to get a flu vaccine or whatever it might be, I always make it a point just to thank the people who show up there, who are working through these COVID policies, who are trying to keep up with all of the information that's out there, just as a show of an appreciation for what that workforce has been doing. And I think that too, we all went into healthcare. I went in, I'm a primary care physician, something very gratifying about those interpersonal relationships with patients, but you have to be well rested, be well fed, be well hydrated. And when you have whatever it is that might be a trigger or some vicarious trauma, be prepared to reach out much as you would have your patients reach out for the kind of help that is most appropriate.
Thank you so much, Dr. Hernandez. Vinder, would you like to add anything to that?
Yeah, I can add briefly. I think that was very well said. The thing that just stands out for us as an agency is really exactly what was said. We just need to squeeze out a little bit of fun. I think sometimes we can get really caught up in quantity versus quality. The numbers and, how many crisis line calls did we answer today? And, we can just get caught up in all of that. And then we really have to consider the quality of the work, and the quality of the work really starts with us. So, we prioritize everything else in our life, right? We schedule our appointments, our sessions, we schedule this and that. And I think, we just have to do better at scheduling our own self-care. But I think also, whatever your setting looks like, whether it's a community-based organization like my sister's house, or if, it's an office setting or a hospital or, the ER department, whatever it might be, schedule time. And I love what was said earlier about saying thank you. And staff, we need to hear that. We really need to hear that. And we may not, I think we hear it from our clients often. But I think as staff, it's really important to recognize what others are doing. And so we at the agency like to do fun things like that, potlucks and dress ups and, celebrating, oh, it's your 1 year anniversary, or, it's your birthday. And we like to surprise one another and just do fun things like that. And even if it's 2 hours out of your 8-hour day, with COVID, of course, there's protocols and things like that. It really is fun. It's light. It makes you laugh. You take fun pictures. It kind of takes you out of that grind and can really help sort of the morale and the culture of your organization and the people that you work with. So those kinds of little things that you can add that really don't take that much time away, but it's something that keeps everyone in better spirits. And then ultimately, if you need help, you have to get the help. Ask for it. We have to take care of ourselves so that we can help, provide services for others. And there's absolutely nothing wrong with doing that. Actually, it should be part of your own, mental health plan as someone who's providing mental health services, being in therapy or going to your support groups or whatever it might be. So that's all I needed to add there.
Thank you so much, Vinder, and thank you so much to all of you for your time. This has been an extremely informative conversation for me, and I'm sure for those watching. Don't forget, this live video can be viewed on demand on the Sacramento Bees and the Equity Lab website at sacbee.com. The Equity Lab relies on donations. To learn more about how to donate and to support our work, visit sacbee.com/equitylab. I want to close by reminding those watching, if you or someone needs any help, please call the California Peer Run Warm Line at 855-845-74 or you can text Talk With Us to 66746 to connect with a trained crisis counselor. Thank you again for sitting down with me and discussing this important topic. Before I go, I just want to remind our viewers to check out the Equity Lab on Instagram, Twitter, and Facebook. And again, you can find those links. You could find those links on the event page. I hope everyone has a great afternoon. And until next time, bye.